All right, hello everyone, and welcome to our Understanding the Rural Emergency Hospital Designation webinar. I'm Sarah Anderson, the Director of Field Services at the Oregon Office of Rural Health, and I'm joined today by Stacy Rothwell. Stacy, raise your hand. Who is ORH's Program Manager for Critical Access Hospital Quality Improvement, as well as Stephanie Sag from the Health Program Manager from the Idaho and the Idaho Flex and Ship Coordinator with the Idaho Bureau of Rural Health and Primary Care Division of Public Health. I will introduce our content experts in just a moment. This webinar is brought to you through a supplement to our Federal Office of Rural Health Policy Flex Grant and the Oregon Office of Rural Health and the Idaho Bureau of Rural Health and Primary Care are collaborating on this project. So we have representatives from critical access hospitals, both in Oregon and Idaho, and I believe a few from Washington actually on this call as well. The Rural Emergency Hospital Designation, or REH, is a new designation available to critical access hospitals. The designation was signed into law on December 17th, 2020, in response to rural hospital closures across the country. And it's meant to address barriers in access to healthcare for rural communities. The conditions of participation for this designation were published by CMS late last year. And we have a website that we have posted those conditions of participation on, and Stacy's going to put that in the chat for us. And we're providing this webinar to help Oregon and Idaho critical access hospitals understand the background of the legislation and designation, the types of hospitals that are likely to convert, what's allowed and what's not allowed when you're converting to an REH per the conditions of participation, and to answer your questions. In addition to this webinar, as I mentioned, the Office of Rural Health in Oregon has created a web page which contains resources to help you understand the designation, including some research articles from one of our speakers, George Pink, as well as the conditions of participation and a link to the technical assistance provider for the designation. I will put the link to the website, or Stacy will, if she hasn't already, put the link to the website in the chat. And Harvey, if we can go to the next slide. Before we get started, I just want to go over a couple of logistics. The audio has been muted and the video is turned off for all attendees. You can select the ellipses to populate the chat and the Q&A features to your right. And we ask that you ask questions using the chat function, and we'll monitor the chat for questions and ask them of our presenters as we go along, and then there'll be a dedicated Q&A session at the end. You can also raise your hand by clicking the hand at the bottom of the screen, and we can unmute you so that you can ask your question live. The presentation slides and recording will be posted within the next couple of days on ORH's website at the link that Stacy's put into the chat. And with that, I am pleased to introduce our speakers, both of whom have studied and researched the emergency rural hospital designation since the beginning and can provide us all with the information critical to understanding this designation. So with us today, we have George Pink, who is the Deputy Director of the North Carolina Rural Health Research Center at Shep Center for Services Research. He's also a professor in the Department of Health Policy and Management in the Gilling School of Global Public Health at the University of North Carolina at Chapel Hill. And also here with us today is Harvey Licht. Harvey is a senior associate with the Varela Consulting Group, where he works on health planning, policy, and program development. He also worked for more than 20 years at the New Mexico Department of Health, where he led the Primary Health Rural Health Office. And prior to working with the state, Harvey was the project coordinator for resources for community alternatives, an agency providing management support and technical assistance to community programs throughout the Southwest. So I'd like to thank you both, George and Harvey, for being here with us and sharing your expertise, and I will turn the floor over to Harvey.
Good morning, all. Hope everybody's doing well. Just to give some background, I put together a fairly large presentation. Again, it'll be available to you includes 3 slides with about 15 different links, including um, links to things like detailed conditions of participation, similar to what Sarah mentioned, payment policies, and other instructions to states on how CMS wanted the rural emergency hospital designation managed. So there'll be a lot of materials for you. And again, as whatever we don't actually cover in the presentation today, there'll be the stack there for you to use as reference. Also, any questions we don't get to during the session itself with its limited time frame, we're planning on, if you do post your question or subsequently have questions and get them to Sarah or Stephanie, we'll put together a little Q&A piece for any topics that we weren't able to address during the session. We're going to focus on the, if you will, an REH, Rural Emergency Hospital 101, which is the basic questions. We've heard them from a number of different folks and wanted to make sure that those got covered. In addition to that, as we have time, we'll like to raise a few additional considerations. So these are additional questions that you may not have asked in terms of considering potential for REH conversion. And then again, a lot of those questions may not have answers, but again, it will give you some sense of the implications of what an REH conversion might lead to, separate from the actual conversion itself. Then last, there is likely going to be some modifications of the model. This was the case with the implementation of the critical access hospital model, where there were probably a half a dozen important changes made in the first 3 years after the designation was implemented. So the last section, which we probably won't cover too much on today, but is to consult later on when you see the presentation slideshow, my speculations on what might happen in the near future in terms of modification of the model. All right, the basics. As Sarah was saying, this is a new Medicare provider category. See the date it was authorized to start on January 1. The final rules, unfortunately, didn't come out too soon before, so that even though the rules are out there right now, they were late getting started. And certainly at this point, I don't believe any hospitals have converted and been approved at this point. It's a conversion only designation. In other words, you have to be in one of 2 permitted Medicare provider categories currently to be able to convert to this. So for example, if you were a federally qualified health center who wanted to add on additional services, you could not become a rural emergency hospital. There is no upgrade path. Similarly, just under half the states have a freestanding emergency department or emergency room classification. These are not recognized by Medicare, and there's no way for conversion from those freestanding sites. Okay. A key comment here was made by the New York Times in a recent article. You'll see the link there. And the headline was $3.2 million a year or inpatient care. And I think that's the main question when considering a conversion, is that there is a subsidy of over $3 million a year that is associated with this conversion, but the cost of that is doing away with current levels of inpatient care for converting facilities. Talk about that more in a second. Right, the 2 categories of folks who can convert to rural emergency hospital are general acute care hospitals with no more than 50 beds in a rural area as defined by CMS, and critical access hospitals who are, of course, in rural areas to begin with. Facilities that were closed prior to the legislation being enacted, December 27, 2020, are not eligible to reopen. But if you're with or know of facilities that closed after that date in the 2 eligible conversion categories, they could reopen as an REH if certain conditions are met. The state, for both Oregon and Idaho and all other states, have an essential role. By statute, an REH must be located in a state that has licensing for this type of facility. So if the state licensing agency does not establish that category for licensing, there is no path to conversion. At this point, I think we're up to about 6 states who have actually enacted supplemental statutes, amendments to statutes to allow this new category. As an example, here in New Mexico, we have a statute that passed its last legislative committee on Monday, and we're hoping that before the end of the session on Saturday, that it'll come to the floor in the last house and be sent to the governor. At this point, neither, and I looked about a week and a half ago, neither Idaho or Oregon has in fact created a separate statutory authority, though I believe that at least one state believes it can manage to establish that new category under a broader hospital definition that they have without having to do statutory amendment. Note also that a state could add additional requirements onto being an REH as long as they don't conflict with federal requirements. And there may be some time needed to actually operationalize these licenses. And again, I think you're all aware of what needs to happen for purposes of having either an attestation or an on-site survey, and the rules, of course, have to be established and all the other things. Realistically, I think we'll be seeing probably no conversions prior to July 1 of this year. And in fact, in a number of cases, it may extend into next year before the state's role in this is well established and the conversions can happen. An interesting question is whether or not, and it did come up prior to us having the session here, is can you revert to your previous status? And there's a number of perspectives on this. My own sense of it is that, of course, it depends. From a state statutory perspective, some of the statutes that are out there, for example, including New Mexico's, are silent on this as to whether or not there's a path back to a previous license status. Kansas, in its statute, actually is a lot clearer. And if you see the example there, it says that a rural emergency hospital shall retain its original license, either as a critical access hospital or a small rural acute care hospital. And that a license shall remain inactive while the REH license is in effect. So there is a path specifically identified, at least from the state point of view, in Kansas, where theoretically, at the surrender of a rural emergency hospital license, a previous license could be reactivated for a given facility, which is interesting. Separate from the state considerations, there's CMS considerations. And it's likely that CMS will treat these reversions in a way as either a reapplication with some sort of facilitated reversion to its prior status. I think one of the questions here that is actually addressed in rule and in statute is that if you're a critical access hospital previously who was designated in the first few years of the program as a necessary provider, which is to say your distance requirements from another facility were less than the statutory mandate, but you were identified as a necessary provider, you cannot resume your previous critical access hospital status. Okay, so necessary provider critical access hospitals, once they convert, don't have a way back to being critical access hospitals. Practically, reversion is an interesting question. We visited with some hospitals yesterday in New Mexico, and the reality is, the important part, I believe, is that financial sustainability, if you had some questions about being able to sustain as a critical access hospital or small rural hospital. Reversion from an REH, it will not make that financial sustainability problem go away. So I think practically the question of reversion is it may be impractical to make that sort of reversion. All right, so what services do you have to have? There are, by statute and rule, there are 5 core services that are required. One is that what they call 24-hour emergency services. Okay, and as defined there, can include either an emergency room with emergency beds or observation beds. But on an annual basis, the average occupancy in terms of patient length of stay cannot exceed 24 hours. So these are not inpatient beds, these are observation and emergency beds. And that's the core service that they're looking at, the emergency room plus those potential beds for emergency and observation purposes. In support of that, the other 4 services that are required are laboratory services, diagnostic radiologic services, pharmacy, and then some level of discharge planning as defined there. The details on this, on conditions of participation as to what those services should look like and what standards they should meet, they're included in the fairly extensive conditions of participation that were released by CMS, and you can access that through a link and get a lot more detail on those. Separate from that, there's a requirement that an REH must have a transfer agreement with at least one Medicare certified level 1 or 2 trauma center. In New Mexico, as an example, there's only, I think we have 3, some of which are a great distance from potential rural emergency hospitals. And many of those hospitals currently have transfer agreements with level 3 or lower trauma centers for most of their transfers. Note that this is not the only agreement that is permitted, but that amongst the various transfer agreements that an REH would have with an inpatient facility, one of those must be with a level 1 or 2 trauma center. Now, what else can you do with this? And it's an interesting question. You could do a lot, and they suggest a number of things in guidance in terms of outpatient departments. Telehealth is specifically referenced. You can operate emergency medical services, ambulance and other extended, do a variety of different outpatient services, and you can have a distinct part skilled nursing facility. Unlike a critical access hospital, where you can have a swing bed, since there are no inpatient beds, you cannot have a swing bed or an inpatient facility as part of the REH itself. But if you have a distinct part skilled nursing facility, that is permitted. And then you can have a continuation of any sort of rural health clinic that you might be operating as part of a critical access hospital or other hospital. The key prohibition is that you cannot provide any inpatient hospital services, including acute care or rehabilitation or psychiatric behavioral health type of inpatient facility. The only type of inpatient hospital services permitted to an REH are those that are provided as part of a distinct part SNF. And lastly, it's worth considering that REHs, unlike critical access hospitals, excuse me, are not 340B eligible. So your participation in that program would end. There's some staffing requirements that are fairly similar to what we see for critical access hospitals, that there must be staffing 24/7 by someone able to deal with emergency medical care, and that your clinician on call should be available, depending on whether you're rural or frontier, within 30 or 60 minutes on call. Okay, it's a fairly broad definition of which clinicians, from MDs, DOs, and non-physician clinicians. REHs are covered by EMTALA, which means you can't refuse folks, among other things. and there are certain quality and infection control requirements. And again, you'll see this in the conditions of participation. The reimbursement piece is an important piece here. I'm going to jump ahead for just a minute. The core carrot in conversion is that there's an additional facility payment, it's called, of over almost $3.3 million a year. This was referenced in that New York Times article, which is a base subsidy that goes to each and every rural emergency hospital. There is no difference between the subsidy, depending on whether you were a larger or smaller hospital, each year, and then increased by a hospital market basket percentage increases. That base amount to sustain the operation, okay, will be made available. Separate from that, there'll be revenue generated from the various services provided. And for the core services, that will be paid at outpatient prospective payment system rates plus 5%. Patient coinsurance won't reflect that 5%. For other outpatient services, it's governed by either the OPPS rate, or for lab services, the Medicare Clinical Lab Fee Schedule. And similarly for SNF, distinct part SNF, the prospective payment system there. And RHCs would be paid at the all-inclusive rate. So that rate may be varied as the facility changes its operations to REH. Ambulance services are paid under Medicare ambulance fee schedule, which are different from those for those critical access hospitals who are currently operating, and this is subset only, on a cost basis. So there is revenues possible at a different basis, certainly for critical access hospitals. That rate is likely lower than the CA rates, okay, but again, the trade-off is the almost 3.3 million annual facility payment. George will talk more about the likelihood of sustainability with these changes in reimbursement. Note that these are all on a fee-for-service basis, and there's no direct mechanism for establishing value-based payments. And note also that this is the payment rules, again, we have a link at the end, reflect Medicare only, and there is separately negotiable Medicaid and commercial reimbursement rate. There's no guaranteed, for example, Medicaid parity with the Medicare payment rate. Okay. With that, just wanted to quickly mention a couple of different things, and then we'll turn over to George. And this may sound silly, but is an REH a hospital is a big question. The definitions of what hospitals are, again, can be modified by statute or otherwise. But if the key question is, if you don't have any inpatient services, despite the name, are you a hospital? And this can have implications, and I think the clearest one are for 501c3 charitable hospitals. Hospitals currently have community benefit requirements, reporting requirements to the IRS. And there's a lot of discussion about what a 501c3 charitable hospital needs to do in terms of providing support to its community. If an REH is not a hospital, okay, the question is, does it get relieved of those IRS 501c3 community benefit requirements and reporting? So there's some interesting implications that go beyond just IRS, but there may be issues in terms of whether this is considered a hospital closure or reduction of services. I was noting, for example, in Oregon, the Legacy Health plan to reduce its services by closing a birthing center needs to go before Oregon Health Authority to get permission. And the question would be, for example, if you're either closing services or reducing services, what sort of review is needed before you can make that conversion? So there's a number of other conditions that may or may not come into play. And some of it depends on whether or not within the state you're continuing to be considered a hospital or not a hospital. Okay. And let me stop there, and we'll turn this over to George.
Thank you, Harvey. Okay, thank you very much for the invitation to talk with you today. I'm going to um, start by uttering two phrases one seldom hears in the same sentence, and that is, I'm a professor, and I'll be brief. So my job today was to present some recent research that we're doing into the new rural emergency hospital. The agenda, we're going to talk about a need for an alternative model. There are many factors to consider when considering and when you're deciding to convert to an REH. Hospitals with low volume EDs may be more likely to convert. The REH model may appeal to a wide range of hospitals, and the REH model has risk. Okay,
George,
the slides are not progressing, right?
they're not.
Okay, so I'm going to use this session. I'm just going to present this way. For some reason, my computer does not allow me to use presentation mode. Is that okay? Can you see that? Is it changing now, Sarah?
Yep, it is. It's great. We're on disclosure now.
Okay, I'm sorry for that. It's just a function of my computer.
No worries.
This is just to confirm that the government has no responsibility for what I'm going to say, which is always a necessary condition when academics present. So the need for an alternative model is growing. Rural hospital closures are continuing. They fell during COVID, but we're starting to see that they're beginning to resume. There's been 188 rural closures since January 2005. In the last 11 years, we saw an increase, and then in the COVID years of 2021, 2022, we saw big drops. Several reporters have said to me, this means that our problems are over, right? And I have to point out that this does not mean our problems are over, because in fact, long-term unprofitability of many, if not most, rural hospitals has not gone away. What we see in the past 10 years or so, these data show you that the percentage of rural hospitals with a negative total margin was trending upward before COVID. During COVID, the federal government shoveled a whole bunch of cash towards hospitals, and rural hospitals were no exception. The provider relief funds and other COVID funding almost certainly provided a lifeline for many rural hospitals that would have closed if they had not had that money. Similarly, we saw that the average total margin of rural hospitals was trending downwards before the COVID funding. All this suggesting that the basic problems and the need for an alternative model, such as the REH, those things have not gone away. There are many factors to consider in deciding whether to convert to a rural emergency hospital. Harvey's done a great job of outlining many of those in his presentation. We have also put together a brief on considerations. We could develop a conceptual model for hospitals that might be interested in converting to REH, and giving them a list of issues that really need to be addressed when considering whether conversion to REH is the good thing for the hospital or not. One study we just recently finished is looking at hospitals with low volume emergency departments. We're just looking at their characteristics, and we found that they not only have lower ED volume, they have lower acute inpatient volume, which is good because that's going to go away with the REH model. They have a lower outpatient volume. They're interestingly more likely to own and operate their own ambulance than to have an RAC. They have access to a CT, which is good, but they have fewer overall physicians. So that is going to be a major challenge as well. And last year in June of 2022, actually June of 2021, when the model was just under development, we estimated we would convene a panel of experts, and we predicted there to be 60 to 70 hospitals across the nation that might be interested in converting to REH. Since then, there have been expressions of interest made by various hospitals around the country. We've gone and looked at those kinds of hospitals, and we concluded that the parameters that we used to estimate the number in 2021 is probably too narrow. And in fact, there may be a wider range. This model may appeal to a wider range of hospitals than we originally thought. And again, the details are in this brief that's at the bottom. And finally, what I really wanted to talk about here today mostly is we're starting to look at the risk. Now, as a finance professor, risk is what we spend a lot of our time thinking about. And in particularly, this is a new type of Medicare payment classification. And CMS and the various presentations I've seen by staff emphasize that this is a new provider type. This is not a critical access hospital without inpatients. That is not what this model is. It is a new provider type. There is no cost-based reimbursement in the REH. It is a new provider type with a new type of payment mechanism. Consequently, there is risk associated with this new payment type. And a lot of it is unknown risk because we do not have any historical experience with this type of model. And when we talk about risk, I'm really going to talk about it in two ways: business risk, which is the volume, the reimbursement and the cost uncertainty, and then the financial risk, because some, if not many, facilities decide to convert to REH are going to need capital to either renovate the facility or replace it. So what are some of the major sources of risk of the rural emergency hospital? The first is, if you're a critical access hospital, you're going to have to transition from cost-based reimbursement to REH reimbursement. Now, this is, I'm a finance professor, so it's mandated under my charter that I have to have graphs and figures. This shows you that under cost-based reimbursement, you have a predictable 1% loss. So you get on your Medicare patient volume. You know that no matter how many Medicare patients, beneficiaries you see during the year, you will receive 99% of allowable cost under Medicare reimbursement. So it is a predictable, it's not a highly desirable rate of return, but it's predictable. You know you're going to lose 1%. When you move to the REH model, now you're into REH reimbursement. For that, it's basically two components. The fixed additional facility payment that Harvey mentioned, which is $3.2 million a year, and you get that regardless of the number of patient visits that you have. I mean, you have to tell CMS what you're going to do with the money, but essentially you'll get the 3.2 million whether you have 8,000 patient visits or 1,000 patient visits. You will then receive the OPPS rate times 1.05. So you get a slightly enhanced OPPS rate, and that will be added to the additional facility payment. So what this graph shows you that is, if you're at 8,000 patient ER and outpatient visits per year for 8 Medicare patients, you will receive the 3.2 million plus about another 5 million in OPPS payment, assuming around $500 per visit for an outpatient. So what does that show you? It shows you that unlike the cost-based reimbursement model where you have a predicted 1% loss, under the REH model, you can lose or you can gain. If you're a relatively low-cost provider and your fixed and variable costs come in under the 3.2 million plus the OPPS reimbursement, you can make a profit. And the more patients you see, the more profit you can make. On the other hand, if your costs are higher than the 3.2 million and the OPPS rate, then you'd make a loss. So this is a very different risk scenario than cost-based reimbursement of CEHs. CEHs, you have a predictable 1% loss. Under the REH model, you can have profits or losses depending on your volumes and your costs. The second source of risk for a CEH is swing beds. As Harvey mentioned, you will not be allowed to have swing beds under the REH model, but you are allowed to have a SNF distinct part unit. If that happens, then you will essentially change from cost-based reimbursement of swing beds of post-acute care to the SNF PPS rate. We did a study a couple of years ago that looked at the difference between cost-based reimbursement for post-acute and compared it to the SNF rate, and we found very large differences in terms of $800–900 per day. So that again, I think, represents a source of risk. The third risk, which Harvey mentioned, is the loss of 340B revenue. The 340B Health Group did a survey of hospitals participating in 340B, found that the average benefit for critical access hospitals is around $564,000 per year, and 3/4 of CEHs reported that they rely on those savings to keep their doors open. So if you convert to an REH, you will lose that revenue, and again, that increases the risk. The next point is the outpatient bypass. This was a study that CMS did about a year or so ago. It didn't get much press, but I think it's an important study. We have also done studies of rural hospital bypass, and what they found was rural Medicare FFS beneficiaries were more likely to bypass their home hospital for outpatient services, particularly if it was a critical access hospital. And ED bypass was highest for patients who were transported by ambulance. So this is an important source of risk, because once you close your hospital and you open the rural emergency hospital, there will be a change in patient referral patterns, patient behavior. And the question is will they show up or not? It's like a field of dreams, if you build it, they will come. I think in this case, the issue is if you build it, will they come? And there's more uncertainty, or will patients just drive to the next closest hospital that's got inpatient facility care in case they need a higher level of care? So there's uncertainty about bypass. Finally, new debt for building equipment. Keokuk Area Hospital in Iowa, they are considering a conversion to REH. They're going to need a new building. If they do that, they estimate that their building would cost about $30 million for 5 to 10 observation beds, lab, X-ray, and so on. For them, it will require new debt. Debt is a fixed charge, as I don't need to tell all of you. So again, if you need renovation or a new facility to become an REH, you may need to acquire debt. That is the source of financial risk. And then there's a whole bunch of other risks, which I'm not going to go into. Harvey mentioned we do not know exactly how Medicaid is going to pay for REH patients in every state. Same with commercial payers. Retention and recruitment costs of providers and staff. I don't need to tell all of you that rural hospitals now have incredible difficulty attracting many types of providers. Whether there's going to be more or less difficulty recruiting staff to REHs is yet to be seen. Some people say easier, and some people say more difficult, because some providers depend on inpatient care may not be satisfied with an outpatient practice only. Patient transfer costs, patients that used to be admitted from your ER now will be transported to other facilities. That will incur, they may incur transport costs. What's that's going to do to your facility and the patients? And then again, as Harvey mentioned, necessary provider status is not on the table. So if you decide to convert to REH and then a year or two from now, you decide it's not working out, you want to revert to critical access hospital, you're going to have to reapply and meet all statutory requirements without necessary provider. And I know that in some states that I've presented in, this and 340B and this requirement are the major obstacles or major barriers to hospitals considering conversion. So in summary, there is business risk associated with conversion to REH, and there's potential financial risk depending on your physical facilities that you've got and how amenable it is to an REH type of model. This is our wonderful research program, and here's some resources we always list. And then the Gateway has rural health research on it, and there is the final slide. Thank you very much.
Thank you so much, George and Harvey. I really appreciate you guys sharing such wonderful presentations, really clear, lines it out. We're going to enter the Q&A portion of our session. Please remember that you can either enter your questions on the Q&A portion of the WebEx, or you can also use the chat functionality. We're monitoring both. Or you can also raise your hand and we will unmute you. So far, we only had one question that came in about the distinct heart sniff. And I really appreciated you putting the link in there for everybody, Harvey. We have had a question about whether or not they can access the slides, and those will be available. And Sarah just let everybody know that we're going to post them on the ORH website. They've got a really nice website, so Idaho's leveraging that as well, along with the recording. We do have a couple of, things that are coming through. Will National Health Service Corps loan reimbursement be allowed under REH? Do either of you know that?
This is where we get to say, gee, that's a great question, because again, I think there's a variety of places where, for example, with loan repayment, there's at this point that special program limited to critical access hospitals for loan repayment program participation. I don't believe that this would be extended because, again, we're moving away from, if you will, an essential community provider as defined by 340B or anything else. But again, this ultimately will end up being an NHSC policy decision. And when their attorneys visit what they're likely to do, as Karnak, I would project that you likely would not be eligible, except to some degree that potentially, if you're operating a rural health clinic, someone potentially could serve on an outpatient basis at that rural health clinic. But I think it's one of those unknowns as this new model gets developed.
Perfect. Do you know why some hospitals might need to build a new facility to become an REH?
And I would say that, I mean, whether it's a new facility or not, and again, there's such a variety of different programs out there, at some point there'll be a need for capital financing. At a minimum, if you don't, for example, have a very well-established telehealth capacity, the cost of establishing that sort of work, which I would say be more needed here, particularly as you have to do transfers and integration with the other health system. Telehealth will become important, and many folks don't really have the equipment and other bases they need there. And certainly as the years go by, the need to renew and improve a facility, if not replace it, should be part of the capital planning for any sort of facility. The difficulty is there is no separate capital financing scheme. There's a bipartisan policy center who was one of the initiators of the current version of the REH model. They've already come up, and I have a link to it at the end of my presentation. They've come up with a variety of recommendations about how to improve the REH model as it currently exists. And they talk specifically about the need, in effect, for Congress to come up with new financing support, either through loan or through grant, for REHs looking to do capital improvement. So I think the question is very much facility dependent. And as time goes on, it also becomes part of the overall question of capital financing for any facility. George, I don't know if you have a separate perspective.
No, I agree entirely. As part of our work, we talked to several emergency physicians who run freestanding emergency departments in rural areas, and their advice was that this is really a new provider type, and an inpatient facility with inpatient rooms, it's going to be difficult to use those kinds of buildings. Now, I've heard some hospitals say that this is going to give them an opportunity to house community-based services and other health services, and to consolidate community services into one building and use the building for those kinds of purposes. So there's mixed opinions. I think some facilities can probably get by with their existing facility. Others are going to have major redesigns.
Okay, thank you. We do have an Idaho-specific question about any timelines for estimates on Idaho legislature changes, or if it's likely in Idaho. And I know Dennis Kelly is on. I'm not sure if he would like to unmute or maybe answer in the chat. So while we kind of wait on that one, Dennis, if you want to unmute, please just raise your hand and let us know. But we also have a question about if there's any predictive modeling studies that have been done that can assess the viability of a CAH moving into an REH?
Let me jump in just kind of more generically, and then let George talk specifically about the models. The link we have, and I know you have it also on your websites, at the end of my, the absolute end of my presentation, there are two links to the Rural Health Redesign Center. They've been provided financial support by Federal Office of Rural Health Policy to do just this type of work on a facility-specific basis. So again, they have technical assistance resources and information resources to help anybody interested in exploring this. First off, look at that question in terms of assessment of the financial sustainability and the financial reasons for potential conversion, but also provide application of the other types of assistance. Now, how good those predictive assessments are has always been a question. And again, George has talked about the risk. And, you know, for those of us filling out NCAA finals trying to predict who's going to be in the Final Four, we all know that risk is a very individual sort of situation for in any given set of circumstances, and how good those models are, I think, it is an interesting question given all the factors that George mentioned. George, I don't know if you have any other more specific answers than that.
No, I posted in the chat the website for the Rural Health Redesign Center. That's exactly the advice I would give as well. I know there are consulting firms going around helping hospitals do this as well, make it financial assessments as well. So between the Rural Health Redesign Center and various consultants, that's probably the route that many hospitals will be going.
Okay. And then what kind of success have you seen in negotiating contracts with commercial payers for these REHs?
Great question. Again, since we don't have any, it's an open question. And
Right.
I would say the first question is willingness of Medicaid and their MCOs to come close to parity on the Medicare side. Secondarily, on the commercial side, I think it's realistic. I mean, I look at FQHCs as an interesting parallel. Again, with cost-based reimbursement in Medicaid and Medicare, they have with the FQAC PPS system, they have a way of getting, I'd say likely within about 85% to 85% of actual cost of operations from those sources of care. By comparison, as an example here in New Mexico, with a fairly substantial FQHC population, in negotiations with commercial insurers, it's about half the rate of reimbursement of Medicare and Medicaid on their cost-based reimbursement. So I'm not particularly optimistic that commercial insurers will work very hard at trying to achieve parity with the Medicare reimbursement rates. I think there's more of a likelihood that Medicaid and their MCOs might, but even there, I think we can't assume that the same levels of reimbursement will happen from those other vendors. Excuse me, those other covered insurers. George, you have a different perspective on that?
No, I totally agree.
Okay, and then we had just what have been the experiences of the hospitals that have converted? Is it working? So since no one's actually converted yet, it's hard to say, but I know it's being watched really closely so that people can kind of learn from others' experiences. Is that kind of what your experience is? And I just wanted, oh, go ahead.
Sorry, the first one was only announced about a month ago, so we haven't got a lot of experience yet. But it will be one of our research missions for the North Carolina Rural Health Research Program. We will be tracking these conversions, and we will be doing evaluations as they unfold.
Okay. And I just want to call out that Dennis Kelly from Idaho did respond to the question about Idaho and had talked about how there will be negotiated rulemaking scheduled for 2024. And I really appreciate you guys pointing to the Rural Health Redesign Center, because I do know there's been a couple of Idaho hospitals that have been looking for some ways to like forecast financially whether or not this will be a beneficial model for them. So thank you. I'm trying to see if there's any other questions. Go ahead.
I have a just an interesting perspective just based on talking to a few hospitals over the last few weeks in our part of the world. In the other considerations section of my presentation, there are numerous questions that can be raised about community governance, community input into a conversion process, and community integration of an REH into a local rural health system. Lots of questions that can be raised there. When we started having conversions into critical access hospitals, there was federal money around to help existing small rural hospitals consider not only just the financial impact, but also the community perception impact. In other words, oh, we don't want to lose our hospital was a big question, and there was a lot of money invested to assure that the community participation and understanding and education around the new model was good, and that the decision to convert was appropriate from the perspective of the community, separate from any institutional perspective. It's unfortunate that we don't have that sort of support for communities to in effect work with their local facilities, community facilities, to consider these conversions. There is supposed to be some level of community consultation, but it is fairly vague and certainly not supported by outside funds. The input we got yesterday, which I thought was very useful, is that, well, gee, if we're losing $1 million a year at our facility, okay, and we don't have time for major community education and input, we need to do this. And there are several hospitals in New Mexico who look at this as a lifeline, and this was their word, that if you look at the REH as a lifeline designation, it becomes clearer. Again, it's a one-way conversion that keeps the facility operational in a downsized version of what it used to be. And it becomes interesting as you all consider the potential for conversion. I would say look at some of the questions that I raised in my deck. George has mentioned that whole question as part of their model. And I think it becomes an interesting question in terms of community understanding of what are you going to be after that conversion.
I would agree with Harvey. I think I mentioned 340B and necessary inability to revert based on necessary provider. I guess the third thing I would add is community acceptance. I mean, the board and the management of the hospital has got to go to the community and say, we think this is the way forward. No more inpatient care. That's going to be that could be a big sell in some communities.
And it raises also that issue of IRS requirements for the 501c3 charitable hospitals. It can be either public or established under nonprofit corporate codes. Right now, there's a requirement not just about community benefit, but there's a requirement that in I think it's every 2 years that a community health plan with an appropriate advisory group be done by a hospital facility who's a charitable hospital, and that there be a community health improvement plan developed and implemented during the interim period. So, and then there's a certain, and I think it'll become more strict, community benefit level of what benefit for your tax exemption are you providing to the community. So if in fact REHs are considered hospitals, okay, you will continue to have requirements about community consultation and community involvement in the planning of services. And that goes beyond what CMS has done and can lapse over for charitable institutions into their requirements if they are still to be considered a hospital under IRS code.
Mm-hmm.
I think it looks like we don't have any other questions coming in for us, but really want to thank you both, Harvey and George. You did a terrific job of explaining all, kind of queuing us up to understand the REH model a bit better. Would you say it's sort of, going back to your last comment, Harvey, a safety net program for safety net hospitals?
Uh, uh, there's a difference between a safety net and I'd say a difference between a safety net and a life preserver being tossed over, over the side of a rescue ship. Again, the folks I spoke to yesterday were saying, gee, we really don't have much choice. At least this will keep us in the healthcare game. Yeah. And again, that 3.2 million, when you're losing $1 million a year on an existing operation, that 3.2 million just to keep something open certainly is not a hard choice. When people converted to critical access hospitals, remember, there was no subsidy like this. That conversion was to be made entirely on the financial sustainability of the new reimbursement model. So this is a very important life preserver for facilities that might otherwise be closing.
Well said. Well said. All right. Well, thank you again. We do have a survey that we ask participants to take. There's an opportunity for you to add additional questions in that survey. Stacy, if you could pop that in the chat one more time, that would be fantastic. As we mentioned, this session has been recorded. We'll put the recording and the slides on our website, on the webpage that was shared kind of towards the beginning. And we'll also email it out to everyone who registered so that you can review the information, and feel free to reach out to myself, Stephanie, Stacy, Harvey, George. Are you okay with people reaching out to you? Great. All right. Thanks, everyone. That is it for today, and really appreciate you all being here. And I'm going to stop the recording here.